afternoon, everyone, and thank you for joining us. I'm Dr. Dania Imam. I'm a family physician working in Calgary.
And I'm Dr. Muzaffar Siddiqui, a neurologist here in Edmonton.
We will be your MCs today, and we would like to give you a very warm welcome to the virtual healthcare conference, which is about various aspects of COVID-19. As you may or may not know, APPNA stands for Association of Physicians of Pakistani Descent of North America. APPNA was established in 1976 in USA, and it is one of the largest medical associations there in the United States of America. APPNA Alberta was inaugurated in 2019. APPNA Alberta chapter organized a healthcare day last year as well, which was a very big success. And we are delighted to host our second healthcare day today in association with School of Public Health, University of Alberta. We will be joined by some of the amazing speakers today who will be sharing with us their experience.
Indeed, thank you all for sharing your Sunday afternoon with us. We've all shared in the collective effort of struggling with the reality of the pandemic. And despite all the personal experiences, protocols, strategies, and life hacks we've all amassed, questions still persist. It really is in an effort to answer some of your questions that we've entreated upon the experts to volunteer their time this weekend. To commence the program, I'd like to ask another expert and personal mentor of sorts, Dr. Ashfaq Shoaib, Professor of Neurology and former chair at the University of Alberta Division of Neurology and current regional co-director of the stroke program, to make some opening remarks. As a young trainee working in his then newly established lab at the University of Alberta's Heritage Research Building, I recall that it was his strong insistence that all the lab students and staff be present for weekly stroke rounds, which was a clinical rather than a basic science learning venue. We all dutifully attended, and it is perhaps now years later that I can confess that it was largely for the pizza. But what the anecdote shares is our appreciation of his long-standing commitment to bridging the gap between basic science research and clinical medicine, and most importantly, public education. Now, there will be no pizza provided this afternoon, I'm afraid, but rather a wealth of expertise and commitment to public health seen collectively in our speakers. On that note, Dr. Shoaib.
Thank you, Muzaffar. This was planned as an event in a hotel somewhere downtown, but that's not going to happen today. It's been a lot of hard work from several committees that were established in Alberta chapter of APPNA. And I do want to thank all of you who have worked so hard to make this possible. I also want to thank the speakers that they've taken out some time from their busy schedules, especially on a Sunday afternoon. And I do hope that for all our attendees, this would be a useful session. We are heading into what Joe Biden had called the dark winter, and it does scare me that we have some tough months ahead of us. So the program, as it relates to COVID-19 and our health, is an important subject to discuss. And I do hope we have sufficient time for the speakers to communicate and also for the attendees to come up with questions. So I'm going to hand it back to you, Muzaffar, and all the best.
Thank you.
Thank you, Dr. Shoaib. And now I would like to introduce in absentia Doctors Nahid Usmani and Rizwan Khalid, the presidents, incumbent, and elect of the APPNA organization, who have been kind enough to submit their recorded messages of support.
Assalamu alaikum, everyone. I am Dr. Nahid Usmani, President APPNA 2020. I'm here to congratulate APPNA Alberta leadership in the COVID-19 initiatives. Today's webinar to celebrate APPNA Healthcare Day includes healthcare professionals who will be addressing a variety of issues related to COVID-19, which will benefit both the health professionals and the general public. APPNA Central has played its vital role during this pandemic, both locally in US and Canada and in Pakistan with its COVID-19 task force and helping national and international efforts of chapters and alumni. They have been matching funds that the chapters raise, thereby enhancing the chapter's philanthropic efforts. APPNA Alberta chapter stands out with its remarkable contributions, fundraisers, series of webinars, and weekly bulletins, and helping the local communities in Alberta and in Pakistan. I was pleased to know that food was distributed to the Calgary Food Bank and aid was sent to Pakistan. APPNA Alberta, keep up the good work.
Well,
Assalamu alaikum and good afternoon, dear APPNA members and friends of APPNA Alberta chapter. This is Dr. Rizwan Khalid, President-elect of APPNA this year and President for next year. I'm recording this message while visiting Pakistan. I appreciate the invitation to send this message. I would like to first felicitate the leadership of Alberta chapter, especially Dr. Tariq Awan, for all the activities of the chapter, including this virtual National Healthcare Day. I have to recognize your active participation in central APPNA activities as well. I congratulate the chapter on its robust participation in APPNA's COVID response, and will also like to acknowledge various chapter members who have actively served in various alumni association and central APPNA committees. I want to acknowledge the Alberta host team led by Dr. Tariq Awan, but also includes Dr. Ishfaq Shoaib, Dr. Hussain Baba, Dr. Saad Yassin, Dr. Samina Bajwa, Dr. Amir Aslam, and Dr. Kishore Jamal. I apologize if I miss any other names. I look forward to your active participation and growth in APPNA in years to come, and especially next year. Hopefully, I will be able to welcome you in person in one of the APPNA meetings in the near future. Thank you again, and Khudafez.
Before we move on to our first speaker, I would like to inform all of the attendees that we will be taking questions at the end of each presentation. You should be able to see on your screen a small Q&A box. You can write your questions during the presentation there, and we will try and answer as many as we can. Thank you. So we'll move on to our speakers now. Our first speaker today is well-renowned Professor Timothy Caulfield. He is the Canada Research Chair in Health, Law and Policy. He is also a professor in the Faculty of Law and Public Health and Research Director of the Health Law Institute at the University of Alberta. Professor Caulfield's crusade to provide clarity in the era of the fake news and junk science has taken him from the halls of academia into our collective bookshelves. Today, he will be talking about misinformation around COVID-19 and how we can fight it. Please welcome Professor Caulfield.
Thank you very much for that kind introduction. And it's a real pleasure to have the opportunity to speak to you today about something that I feel really passionate about, as you highlighted in my introduction, and that is battling misinformation, particularly in the health sphere. It's something I've been doing for decades, and I have never seen anything like I'm seeing now. It really is an extraordinary time. There's misinformation about absolutely everything out there in relation to COVID. And as I'm going to argue in the brief amount of time I have with you, it is doing real harm. So what I want to do is I really want to map some of the big myths that are out there, and you guys have heard them, you know what they are. I want to talk about the harm that it's doing, but more than anything, I want to really encourage everyone involved in this event to become a crusader. You know, people that can fight this misinformation. You're all respected experts, you're respected healthcare providers, and it's exactly your voices. It's your voices that are needed to fight what's been called. It's been called the infodemic, right? This is what the World Health Organization identified it as, you know, really early days, and it really has been a destructive force. And this is something that we were studying at the Health Law Institute. We have several grants looking at this, and so I really want to talk about some of the things that we've found and what you guys can do. So let's talk about some of the misinformation that's out there. There's those big things. You guys know this. There's misinformation about where it started. There's this idea that it was created by 5G technology. I don't know if you guys have heard that, but it's an extremely popular myth. The idea that it's a bioweapon that has come out of China. There's even a myth that it came from a comet. That has actually become a relatively recent one. And then all the other conspiracy theories, the idea that big pharma is associated with it, for example, all getting a lot of traction. In fact, I'm almost certain that COVID-19 came from the grassy knoll. You heard that from me. It is an incredible amount. There's an incredible amount of noise out there. And what is also probably equally amazing is the number of people that are at least open to these conspiracy theories. This is data from the UK that found about a fifth of them believe that COVID's an out-and-out hoax, that it's not even a real thing. Data from the US, you find numbers like this. In fact, this was relatively recent, and since this Pew survey was done, the numbers have even increased. But 3 in 10, or 4 in 10, depending what survey you look at, believe that it's a bioweapon. This is one of my favorite examples because it's so absurd, it's so crazy. This was a poll that was done in the United States, and it found that only 1 in 4 Republicans disbelieve the Bill Gates conspiracy theory. And the reason I love this one is that's a hardcore conspiracy theory. This is the belief that Bill Gates started the pandemic in order to vaccinate the world so he could put a microchip in all of us and monitor our movements. It's really absurd. But look at this. This was a study, even a little more recent, that found that 28% of Americans believe that hardcore conspiracy theory. This was a recent, fairly large study that came out, and it found about half of Americans believe one of the big conspiracy theories. That's worrisome, but also very worrisome is the numbers that believe misinformation that really impacts the public health and activities that we all need to adopt, right? Like wearing masks, and there's this strong belief that hydroxychloroquine works. What about Canada? Well, the numbers here are pretty grim. This was a survey done by colleagues of mine at Carleton University, and they found about half Canadians believe one of these big conspiracy theories. This is just one example from that survey. You've got 26% of Canadians believe in the bioweapon conspiracy theory. And why is that the case? Well, a lot of the misinformation is coming from social media. Studies, we have a body of evidence starting to emerge on this. We've done some of this work ourselves, and we found absolutely no surprise to you guys, but good to have the data, right? That a lot of this misinformation is coming from social media. This was a study from McGill that found exactly that. Those that get their information from Twitter and Facebook and Instagram and TikTok, more likely to be misinformed. This was a study from the US. It's kind of interesting. They looked at thousands, over 7,000 bits of misinformation. And what they found was 4,000 of those bits of misinformation came from Facebook, or had Facebook as the primary source. So they really point their finger at Facebook. But I think it's really social media more broadly. Celebrities, I'm very interested in pop culture and the impact it has on our beliefs. Celebrities, prominent individuals also having a really big impact in this space, you guys. Woody Harrelson, a well-known actor, he had played a big role in the spreading of 5G. The 5G myth. But look at this study that came out of Oxford. I find this one really fascinating. What they found, one of the reasons I find this is useful, it really highlights how it's a top-down, bottom-up phenomenon, and that's good to know when we're trying to fight this, right? So what they found is they looked at hundreds of of bits of misinformation circulating in pop culture that has been shown to be wrong. And they found that about 20% of those had as their origin a prominent individual, okay? But look at the second number, 69% of what's circulated on social media is us circulating that information, right? So I think that's really important to recognize, and I'll come back to that at the end. This is a remarkable study from the US where they looked at millions of bits of misinformation, and they found a remarkable number, but it backs up the Oxford study. 38% of the misinformation that's out there has a connection to Donald Trump. So that's where they get this headline, you know, the single largest driver of coronavirus misinformation. But we have to remember, we're circulating that nonsense. Yes, he may start it, but we're circulating it. And the other number, which is overlooked in this study, hasn't got as much attention, but I think is as important. Only 16% of that misinformation is corrected. So that's a real call to arms, right, to everyone involved in this event. We've got to get out there. We've got to correct it. Misinformation is also circulating as commercial content. For example, on Instagram. So this is, you know, some research that we've done. I've actually personally looked at hundreds and hundreds of posts on Instagram. And you guys, I'm not exaggerating. I didn't find a single example of immune boosting being accurately portrayed. Not one. And you think about, you guys know that immune boosting is kind of an iffy scientific concept. You can't really boost your immune system. In fact, you don't want to. That's anaphylaxis. That's an autoimmune disease. But a lot of people trying to sell product out there. And here's one of our studies that we just very recently published. And what we found was almost everything on Instagram is devoid of science, and it's commercial content. And they often use sciencey language to try to basically sell stuff, right? That's what's going on. This was another study that we published on Point. This is a preprint, but it has been accepted for publication. It's coming out in BMJ Open very, very soon, I think. But here what we did is we looked at hundreds of websites. Like, we tried to pretend we were a patient or someone in the public searching about immune boosting. What do they get? What do you get when you do that? And we found 86% of the hundreds of websites that we looked at represented it inaccurately and portrayed immune boosting as something that was beneficial for avoiding COVID-19, which was really incredible, right? But I also think that the lower number there, that 10%, is also remarkable. Less than 10% of the websites had any kind of critique of immune boosting. So I think this is really important to recognize. This is what your patients are seeing when they search this stuff. This is what the public is seeing. And you need to know it's almost entirely inaccurate and probably harmful. So what's the impact? You guys know what the impact is, of course, but let's go through it real quickly. Physical harm, there have been deaths associated with it, hospitalization, increase in stigma, property damage. I think there's a lot of science and health policy concerns that we can come back to maybe in the Q&A, but it also just adds to this chaotic information environment. And research tells us that, you know, a chaotic information environment makes it more difficult for the public, for your patients, to tease out what's real and what's not real. And lots of evidence to back that up. Other tangible examples, you know, arson, assaults, you know, people embracing conspiracy theories, racial tension, poisoning. This was an interesting study. You have to be careful not to overinterpret these kinds of studies because it's correlation, not causation. But they correlated thousands of hospitalizations and hundreds of deaths to one single rumor about alcohol being a cure or a treatment for COVID. So this really, really does matter. And the other thing, you guys, and there's a growing body of evidence on this, all this misinformation also has a big impact on the likelihood of people adopting preventative strategies, wearing masks, right? You know, physical distancing. This is really having an impact. And I'm worried now that we're in this next wave that this is going to have an even greater impact. And of course, in the context of vaccines, you guys know this, right? It's really having an impact. So this was a Angus Reid study, kind of depressing. In July, they found that only 46% of Canadians said they would get the vaccine right away. And look, it's deteriorated to 39%. Look, the 46% was depressing. That's already too low. And it's deteriorated to 39%. Now, look, I know people are saying they want to wait and see about efficacy and safety, and they may eventually get it. But I think this is a really good metric of the impact of this misinformation and the erosion of trust that's happening out there. You know, so it is really problematic. This was a really nice study that kind of brings together a lot of things I've already said. It just came out. And what they were really doing is just mapping, you know, the impact of misinformation and how it plays out. no surprises, but I like the conclusions. It really brings everything together. If you have a higher trust in scientists and higher numeracy skills, which is really just critical thinking skills, you're less likely to believe misinformation. No surprise, right? They also found that if you believe misinformation, you're more likely to be vaccination hesitant, less likely to adopt those preventative strategies. Again, no surprise, but good to have the data. And of course, I love this ending conclusion. We need critical thinking skills. We need to increase the trust in the scientific community. And of course, we've got to debunk this stuff. We've got to debunk this stuff. And that's what I want everyone here to do. Now, people might hear that debunking doesn't work, right? But there is a body of evidence that suggests that it does work. This is an recent meta-analysis that came to that conclusion, that there's cause for optimism if you adopt the skills that I'm just about to pass on. It does have an impact. You know, I did a literature review myself, published it very recently, came to the exact same conclusion. You know, despite sort of pessimism about debunking, it really does work, especially if it's done by experts, especially if it's done by the people on this call, the people involved in this event. We need you guys to do this stuff. So what do you need to do? Well, this is a great study that came out just last year, and I love this headline. Yes, it is worth arguing with science deniers. What do you need to do? Well, you do. This sounds ridiculously straightforward, but there's good empirical evidence to back it up. You highlight the good science, the trustworthy science, and you highlight the rhetorical devices that are used to push the misinformation. So you say, look, here is this meta-analysis and systematic review. And by the way, that denier is using conspiracy theories. They're misrepresenting risk. They're just using testimonials and not good empirical data. You do that, you can have an impact. And the other good thing about this study is they found no evidence for what's called the backfire effect, the idea that providing science causes people to become more entrenched. So here are my favorite tips for effective debunking. You know, take a screenshot of this, take a photo of this. Whenever you see misinformation, use these tools. So first of all, provide the good science. Yes, it does work. Use shareable, clear content. Think about what your message is going to look like on Twitter, on Facebook, on Instagram. You know, turn to those trustworthy, independent sources. If possible, point to the scientific consensus. And there's a lot of really interesting data that says that this is important, coming from the vaccine world, coming from the climate change world. And by that, I mean, say, look, here is a body of evidence. Yes, there may be small studies here and there, but here's the body of evidence on the topic. Good example is masks, right? Here's a body of evidence on masks, and what does it tell us? And the other thing to highlight is that science evolves, right? It's not a list of facts, science evolves. If you do that, you can have an impact. The other thing, you want to be nice. It can be hard when you get frustrated, but you want to be nice, you want to be authentic, you want to be humble. That really does matter. You're more credible if you adopt that tone, right? If you really are authentic, and there's a good body of evidence that suggests that's the case. You know, use creative strategies, use a story, use art, use humor. As I say here, creativity wins. As I said earlier, you want to highlight those rhetorical tricks, those gaps in logic that are used to spread misinformation. Number 8 is important. Make sure whatever you do, make the fact, the truth, the memorable thing, you know, not the misinformation. You want to make the truth the thing that they're going to remember. And number 9, you guys, so important, especially, you know, I find this really important personally because I spend so much time doing this. Remember, the general public is the audience, not the hardcore denier. It's so easy. It's so easy to get pulled into a vortex arguing with a hardcore denier, someone who really is entrenched in their view. And I can promise you, this person holding up the medical fascism sign, we're not going to change her mind. We're not going to change her mind, but we can use a discussion with her to have an impact on the general public. So this is a report from the World Health Organization. I think it's very useful. And they point out exactly this. We're not going to change her mind, right? She's a hardcore denier. It's going to take a lot of resources, a lot of energy to change her mind. But she does, her rhetoric infects everyone else and creates hesitancy amongst other people. So we want to make sure our message is for the general public. And that's why for the World Health Organization, rule number 1 is the general public is your target audience, not the vocal denier. So don't waste your energy on them. And rule 2 really touches on my top 8 things there. Correct with good science and unmask those tricks, those rhetorical tricks that are used to push misinformation. The last thing I want to leave you guys with is this. This is the idea that we really have just got to get the public not to spread the misinformation. Remember I said earlier, this is a top-down, bottom-up phenomenon. Well, this is research done by one of our colleagues, Gordon Pennycook at the University of Regina. And what he found was that, look, Canadians want to be accurate. They don't want to spread misinformation. So if we can just get Canadians to pause, nudge them to pause and to think about accuracy, they're less likely to share online. I know that sounds ridiculously simple, but there's a growing body of evidence to support this. So we're trying to do exactly that. We've partnered with this entity, Media Smarts. They're a media literacy organization, to really encourage Canadians to check, then share. So go to this website, you guys. You don't need to pause. You don't need to hesitate. Go to this website, get this content, and share it with your patients. Get them to pause before they share content. As I say here, check first, share after, and we can all make a difference. We can make a difference with your patients, with your public, and really with all Canadians. So I'm going to end there and say thank you very, very much for this opportunity. I know this was quick. I hope you guys have some questions. Really looking forward to it.
Thank you ever so much. Professor Caulfield, that was really an engaging and timely presentation and the perfect introduction to this afternoon's discussion. I find myself wondering if perhaps you and your team are often inspired by the ghost of Marshall McLuhan in your work.
For sure we are. I mean, this is a very complex area, and the message is the medium, I guess, or the medium is the message, right?
Yes.
And the mediums are constantly changing now, right? It really has become an underlining part of the story.
Absolutely. Professor Caulfield, we do have one question here from one of our viewers who also, like myself, happens to be a frontline healthcare professional, a stroke neurologist here in Edmonton. And the question is, can you comment somewhat on what might seem immediately apparent really in our presentation, but what aspects of this phase of the pandemic and our collective psychological responses to this are making people more receptive to the onslaught of misinformation?
Yeah, this is a great question. And I think that there are a number of forces, and there's actually a little bit of data to back this up. There is growing COVID fatigue. I'm sure everyone involved in this event is sensing that with their patients. That might invite people to be more susceptible to misinformation. The other thing, I actually have some slides on this I took off. There's growing polarization in the public discourse, very intense in the United States. There's been some really interesting research to back that up. Republicans and Democrats just talk about this completely differently, right? So that's, I think, helping to drive a further interest in misinformation. And there was another study that was done in Canada, I think it came out in mid-September, that found that 57% of Canadians now are starting to relax their preventative strategies. They're starting to think that even though the numbers are going, they're starting to relax. And 23% of Canadians, which is a growing number, think that health authorities are exaggerating the harm. So all of these things, I think, are making people more susceptible to misinformation. And I do think it's not as bad as the United States, but we are starting to see this ideological shift. And there's really interesting research to back that up, that there is sort of an alignment with ideological positions and people's belief in misinformation, unfortunately. And sorry, I'm going on too long, but it is an interesting question because this is something I'm writing about right now. Once someone adopts it as a behavior, like they're anti-mask or anti-vaccine, or they think it's been exaggerated, once that becomes part of their personal brand, their personal ideology, it becomes much more difficult to change their minds, right? So we really want to get to people before that process happens. And that's why some scholars really think it's important to hop on misinformation really quick. There was a study from the US that suggested one of the reasons the 5G thing spread is that we didn't get on it fast enough, right? We didn't debunk it fast enough. So there is a timing component to this also. Sorry, I went on too long, but it was a really good question.
No, no, not at all. I think those are all very vital points to highlight, and I think address a lot of the questions that many of us are harboring. You know, on that note, you did point us in the direction of some resources in your presentation. And as a note to the viewers, this webinar will be recorded and you'll be able to reference it subsequently at the Facebook page for the APPNA Alberta chapter. So hopefully, if you haven't written down the resources that were highlighted in Professor Caulfield's presentation, you certainly will be able to access it. But on a parting note, Professor, can you share or reiterate some of the resources you highlighted, as well as perhaps specifically point to some resources that you've identified as oases, if you will, of reliable evidence-based information?
Yeah, those are great questions. There are, I always say we should go to trustworthy sources that are aggregating the information in a responsible manner. And I still think that those are the big public health authorities in Canada and around the world. So the World Health Organization, the Public Health Authority of Canada, I actually think the provincial agencies have done an admirable job. Yes, it hasn't been perfect. Everyone's learning as they go. But in general, I think these are really, really good sources. The World Health Organization has a wonderful myth-busting website. So World Health Organization, Google World Health Organization, myth-busting and COVID. And the reason I really like it, you guys, is they provide you with these infographics that you can share with your patients. And they really do try to tackle a lot of the big things that are coming out. So that's a really good resource. You can go to our website, Health Law Institute, and we have information about how to fight myths, right? We have a good infographic. I like to think it's really good that you can share that that has a lot of the information I actually had in my talk. And Media Smarts, that entity that we're working with. So if you Google Media Smarts misinformation, they also have content, again, that you can share with your patients, you could share online about fighting misinformation. But also they have a wonderful list of resources that you can go to. And for example, the World Health Organization is in that list too. So that's a good place to start. I think those are good ones.
Thank you. That is really a great list for starters. And I think as a note to self, we'll endeavor to perhaps compile those links and add that as a supplement to the presentation on our website as well. I see a lot of our viewers coming in with the sincere expressions of appreciation, Professor Caulfield.
Thank you.
And let us reiterate that for your really timely, engaging, and passionate entreaty and very timely debunking. Thank you again.
Thank you so much, you guys. I hope the rest of the event goes very, very well. So yes, thanks again. And I like to end with my two favorite words: go science. Great.
Right. Okay.
See you guys. Have fun.
Thank you. Well, I'd like to thank Dr. Caulfield in absentia again for really that engaging and vital presentation. Our next speaker is a hometown and home team player of sorts. Having grown up here in Edmonton and trained at the University of Alberta, her training and professional work in the fields of family medicine, travel medicine, and public health have taken her around the country and around the world. A review of her published work indicates the work of a veritable virus hunter, centered on recent emergent infectious threats that have tellingly foreshadowed the emergence of the COVID-19 pandemic, from the Zika virus in South America to the yellow fever hotspots in Africa. She's thus eminently qualified to share with us the evidence surrounding public health measures and their practical implications in our daily lives, ranging from the day-to-day measures we take to the prospect of choosing between travel plans and the proverbial staycation. Please join me in welcoming Dr. Khatib.
Thank you, Muzaffar Bhai, for the introduction, and thank you, APPNA, for inviting me to speak today. And yes, even though I'm based in Toronto, I am through and through an Edmontonian. And it's a pleasure to be back speaking from my alma mater, the University of Alberta, where I did train my undergrad as well as my medical school. So thank you once again for having me speak on this very important topic. So today I will be addressing COVID-19, the elderly, and chronic disease management during the pandemic. And I know this is something that has caused a lot of anxiety for a lot of families. And so we're going to go through that. And just going to move this here. Okay. So the objectives of my presentation today is I'm going to speak a little to age and chronic disease as risk factors for COVID-19, the access to primary care during the pandemic, household transmission risk in the context of school-going children and the elderly, and some prevention strategies that we can look at to help us as we go into, as Angola Schwach says, this dark winter that we are coming into. So if we look at the age distribution of COVID-19 cases across Canada, we can see that the actual case numbers are very variable across the different age groups. But what is important here to see is that the actual case numbers in the demographics over the age of 60 is a lot less compared to those that are in the younger age groups. However, if we actually look at the number of COVID-19 cases that are hospitalized in Canada, we'll see that a huge proportion of those that are hospitalized, almost 90%, are those over the age of 60, which isn't in line with the number of cases circulating. So that goes to show basically the increased risk that we're seeing in those who are in higher age groups. And furthermore, the actual age category of COVID-19 related deaths in Canada are very highly represented by those over the age of 80, but again, increasing from the age of 60 and up. So that brings me into looking at who exactly is at risk of having a severe disease outcome from COVID-19. So definitely older adults over the age of 60, increasing with increasing risk with each decade. Those who are immunocompromised, who may be suffering from cancer or who may be on medications that suppress their immune system, such as chemotherapy. Those who are obese, and people of any age actually with chronic medical conditions. And when I talk about chronic medical conditions, this varies and encompasses a huge different types of medical conditions, from heart disease, kidney and liver disease, including those who may be on dialysis, high blood pressure and hypertension, those who have suffered from dementia or stroke, anyone with lung disease, including COPD or chronic obstructive pulmonary disease or asthma, current smokers, and those who are diabetics. And actually, if you look at the percentage of Canadians over the age of 65, over half of them have at least one reported risk condition, including asthma, cancer, COPD, diabetes, obesity, heart disease, or stroke. But I also just want to draw attention to this category, because I know we always talk about those in the higher age categories, but if you look at the 50 to 60%, 50 to 64 age range, the percent of Canadians with any high-risk condition is reaching up to 50%. So it's often important to think of this category as well as being at higher risk if they have a chronic condition, even though they don't meet that age category of high risk. So I'm going to speak to a little bit about access to primary care. So what we saw during the beginning of this pandemic is that there was a huge concern to access and cost of personal protective equipment when it came to primary care, family physicians, hospitals across Canada and the States. And there was a really big push to ensure that doctors' offices were COVID safe. There was also a need to protect caregivers from infection and preserve hospital capacity for the expectant surges that we were expecting. As a result, there was a rapid adoption of distance medicine via virtual medicine. And by June, 2/3 of doctors were delivering most patient care via telephone or virtually. By May, 47% of Canadians had used virtual care, such as calls, emails, text, or video during the pandemic. Now, this is compared to at least 4% of those who are using virtual care pre-pandemic. What worries me, though, is the actual 53% of Canadians who are not using virtual care, who are not getting access to the care that they may need. There are limitations to virtual care, so not everyone has phone and not everyone has access to the internet. Not everyone knows how to use email, texting, or video app platforms. And virtual medicine can be very difficult for those who may be in the more vulnerable categories, such as older patients, those with disabilities, and those with language barriers. We have also seen people with increased isolation because they're not having access to going out to see their family doctors or their hospitalists. But there are also this feeling of being a burden to those on the front line. I've had a lot of patients call and say, oh, I didn't want to bother you because I know how busy you are. I know how busy things have been with COVID. So I've left this until now. So that's also another kind of feeling that people are feeling throughout the community. And then again, there's a loss of these subtle nuances and cues that we see when we see patients. We have a visual and a sudden gestalt of how these patients are doing. So what actually has been the impact on chronic care during the pandemic? Well, first of all, breast, cervical, and colon cancer screening tests were put on hold in primary care, and all non-essential elective care was paused. Across the states, 41% of US adults had delayed or avoided medical care, including urgent or emergency care and routine care. Now, delayed or avoided medical care can actually increase the risk associated with treatable and preventable health conditions, which is quite concerning. And as a result of this can be increased reported deaths related to COVID-19. And if you actually look at the footprint of the pandemic, and what we're seeing is that the first wave showed us, a huge focus on COVID and the immediate mortality and morbidity associated with that. The second wave of pandemic is we see a huge impact of resource restriction on COVID, non-COVID conditions, and the ones who are not getting access to more urgent needs, such as surgeries, for example. And then the third wave, which we may not be seeing until much later, is the impact of interrupted care on chronic conditions. We are seeing a little bit of it now, but I feel, given the current situation, that we're going to see a huge impact of this down the road. And then, of course, the fourth wave that Dr. Raheel Syed is going to speak about is the impact on mental illness and the psychic trauma. If we look at the impact of COVID on routine care for chronic diseases, a global survey was done from health professionals around the world, showing that diabetes, chronic obstructive pulmonary disease, and hypertension were actually the most impacted conditions due to reduction in access. Of course, 80% reported mental health of their patients had worsened. And most global healthcare resources were focused on COVID-19, which was disrupting the continuum of care for patients with chronic diseases, and that continues to be the case. But if we look at actually all the chronic diseases that are impacted, it's not just diabetes, although that is the one that's the number one impacted, but it includes heart disease, asthma, depression, cancer, obesity management, chronic kidney disease, and those who have been affected by stroke. More so, a lot of the preventative services, routine monitoring, and treatment of chronic diseases that are done to really prevent secondary complications have been really restricted. And this, what I know it's a little bit of a busy slide, but on the left, what this shows is the screening test for HbA1c, which is the test for diabetes, and LDL cholesterol. The screening tests between February and March decreased by about 80 to 90%. And that impact has actually lasted, and we're really seeing a backlog, and we're not seeing that rebound coming up to where it was before the pandemic started. Also, we're seeing about 50% reduction in new prescriptions, and in this case for metformin, so people who are newly started on metformin for diabetes, or for statins, which is a cholesterol lowering medication used in secondary prevention. Those have been 50% reduction, and again, that continues to not show any sign of rebound. So if we're looking at these particular treatments of lipid disorder and diabetes, these, in fact, have been shown to be life-saving. And although it may be safe to temporarily defer them during the current COVID crisis, in lieu of other more acute services, the cumulative risk of this over time may be significant, and it's still something that we don't know what the repercussions will be, but we have an idea that a lot of preventative care may be thwarted because of this. So in countries like Canada, with accessible healthcare and higher proportion of people living with chronic conditions who have been stable up until now with heart conditions and stroke, the COVID-19 death rate is actually higher in these places. And the reason is that because these people have been so stable with these chronic diseases, it all of a sudden does put this cohort, though, at a higher risk of developing more severe conditions if they're not being maintained. So for every 1% increase in the size of a country's population with heart conditions or stroke, the death rate was higher, up to 19%. And for every 1% increase in the size of a country's population with people 65 years and older, the death rate was 9% higher. And that may not be due to the age specific, but the fact that this cohort has more comorbidities that make them higher risk. Also, there's been an impact of medication shortages and patients running out of meds earlier, so they haven't been compliant with their meds. People really rely on checkups or hospital visits for multiple chronic conditions to manage their risk factors. And these delays will really have severe consequences. In Ontario alone, we're seeing 1,200 medical procedures being postponed monthly, and there's a huge backlog. And also caregivers that are becoming overburdened because community supports aren't available. So a lot of the respite is being sought in the emergency department. On the flip side, there's been a lot of anxiety about seeking care. And between March and June, we saw 25 to 50% decrease in emergency visits across Canada. This also included delayed presentations of heart attacks, strokes, and infections. I heard of a story of a man who had chest pain for 3 days, and he finally presented, but when he presented, he was in heart failure. I heard of a woman who had numbness and signs of stroke on her left side who waited for 12 hours thinking that it would just go away. And of course, multiple stories of people with ruptured appendices who presented. And because of these delayed presentations, they're having higher complications and worse outcomes for diseases that have been potentially preventable, but also are time sensitive. We've all heard that time is heart, time is brain, and really a lot of these presentations are being delayed and affecting the ability to give proper care. So it's really important to focus on routine preventative care to avoid a rise in non-COVID related morbidity and mortality. And I think people can look at using apps to support self-management at home, but also making sure that people are getting timely treatment for their ongoing chronic conditions so that they don't become worse and eventually have a greater impact on the healthcare system. This is just something that one of my coworkers, Dr. Tara Kieran, has just published in the Canadian Family Physician. And it's basically a way of looking at primary care needs to develop a new approach to delivering care that really supports evidence-based interventions, but balances risks and benefits of in-person and virtual visits. And we've seen this with pregnancy protocols and with vaccinations for children. This is a great resource that's just come out in regards to managing diabetes in the primary care setting, which I think will be really important and helpful going forward through the pandemic, especially given into the second wave. And remember to the public that doctors are available to provide care for you, COVID or no COVID. That's our job. We're here to care for you. We want to see you virtually. If you're having an emergency situation, we want to see you in the emergency. Yes, there's limited in-person to help prevent the spread of COVID, but doctors are available virtually. They're available to see you in person when it's necessary, given the appropriate protocols. So reach out and find out what care you need. If you don't have a doctor, Alberta Health Services has resources available. And of course, if you're having a medical emergency, call 911 or visit the nearest emergency. I'm just going to switch gears quickly here to talk a little bit about grandparents in the context of school-going children. So according to Stats Canada, Canada is home to more than 7.5 million grandparents. And there are more than 400,000 multi-generational households in Canada. Some families really rely on grandparents for pickups and childcare. And people, of course, we know over 60 are also at risk of getting more sick and dying from COVID. So what's the risk? So children appear to have milder symptoms, low risk of severe illness, and a lower likelihood of transmitting COVID. The Government of Canada reports that 7.1% of all documented cases are under the age of 19. And we know that child to adult transmission appears to occur at a lower rate than adult to child to transmission. Also looking at transmission in schools and daycares, it's variable, but outbreaks are really described mostly in areas with higher community transmission. So can school-going kids still see their grandparents? Really, I think we need to be taking a cautious approach until the impact of school reopening is more clear, and especially going into the second wave. I mean, Ontario has now reached over 1,000 cases today. We've hit a milestone, the highest case count we've had during this entire pandemic, which is very worrisome. Alberta's numbers are going up. But this doesn't mean cutting off contact with your grandparents. It's important to maintain distancing, looking at options to meet outdoors, using technology. And in cases when caring for children, grandparents should really consider distancing, wearing a mask, and everyone should be washing their hands frequently. If you're living with your grandparents, consider having them living in separate areas, disinfecting common surfaces, and distancing as much as possible. The household transmission risk, a study published by CDC shows that children 9 and under were infected others in their household 5.6% of the time, whereas those between the ages of 10 and 19 spread the virus at the same rate as adults, almost 19% of the time. So again, it's more likely for an adult to transmit COVID to another child than for a child to transmit to other children or adults. But remember, the household secondary attack rate is high. It's 16%. And as we go indoors with the colder weather, this is something that we really need to consider to protect our families. So individual families will really need to determine the level of risk that they're comfortable with. And I know people talk about opening up their social bubbles and how school really opens that kind of warms up, but really it's just one layer of protection. And I like the Swiss cheese model because it talks about looking at hand hygiene and masks and distancing and testing and staying home when you're sick, and really using each layer as another layer of protection. And now more than any time, it's very critical to take these extra precautions when it comes to our elderly. And just a plug, talking about elderly and the people with chronic conditions and children. I love this picture. It kind of shows us that we're not very far from where we were in 1918 during the Spanish flu, and a lot of history seems to be repeating itself. But we're entering flu season. Professor Caulfield talked about an infodemic, and I'm here talking about potential twindemic. This year will be more than ever crucial in getting vaccinated for the flu to reduce that risk of overwhelming the healthcare system, and the presence of underlying comorbid conditions really increases that risk of death from influenza. Everyone's talking about the COVID vaccine, but we have an effective vaccine for influenza, so get vaccinated. And remember, those who are at higher risk of flu are also high risk of COVID. So people with chronic conditions, those under the age of 5, those over the age of 65, follow public health guidelines as recommended. Remember the 3 C's of prevention: avoid closed spaces, crowded places, avoid close contact, stay connected, and stay safe. And thank you very much for having me today.
Sorry, I don't know if you could hear me. Thank you so much for joining us today. It was a great presentation. What would you recommend about visiting senior family members in the extended homes? There has been a lot of apprehension about it and lots of restrictions as well. What would you recommend?
Generally, the recommendations right now, people should really limit the socializing. So if people are not living under your household, really you should be limiting the contact with them. And if you are visiting, if you're saying it's a family within, your extended family that's still within your bubble, still really maintaining distancing. If you can meet outside, it's better. Otherwise, if you're meeting indoors, anytime you're indoors, you should be masking. This is more for the adults and older children. Obviously, it's difficult for some of the younger children to be masking, but again, the risk is really not so much from the children to adults as much as to adults between each other as well.
Thank you. And could you please just also re-emphasize the evidence-based measures for the prevention, of course, of the infection, social distancing, masks, sanitizing?
Right. Absolutely. So the measures that are recommended by public health have been evidence-based to decrease. And so first and foremost, wearing a mask, right? That has been shown to decrease transmission from yourself to others. We know that this infection is spread through droplets and aerosolized droplets. It's a respiratory infection. So minimizing that by wearing a mask, increasing the distance, so minimum of 2 meters. If you're going to be visiting anybody or if you're going to be outside even, you should maintain the distancing. Washing your hands frequently, right? Because these are spread by droplets. If you touch your hands that have been infected by potentially droplets containing the virus, and then you touch your mouth or you touch your eyes, you potentially could be infecting yourself. So frequent hand washing, that goes also with frequent disinfecting of common surfaces. Again, just following the public health recommendations that are outlined.
Thank you so much. And we do have another question from our fellow physician that she's basically asking, do you think there will be less cases of influenza this year because of the precautionary measures that the people are taking because of the COVID?
Yeah, absolutely. So actually what we saw in the Southern Hemisphere is that, the case counts for influenza went from about 30 to 50,000 in Australia to really a handful per cases that they're counting per day. But the difference from the Southern Hemisphere to now is that they went into their flu season while they were going into lockdown, while travel had been restricted, when social distancing, hand washing was being enforced. They also had an unprecedented surge in flu vaccinations. 70% of their population was vaccinated. So what's different for us is we're opening up. There's a lot of COVID fatigue. People are becoming lax with, the measures that they're taking. The other thing is that because there was such little flu circulating, we actually don't know what the impact is going to be in the Northern Hemisphere and how effective our flu vaccine is also going to be. So the other aspect is we know there's cases of COVID and flu that have been together. And the reality is that we know that they're likely to cause more severe cases. We just don't have a lot of that. And so the last thing we need is, people being either co-infected or cases of influenza overwhelming the hospital capacity, as well as COVID-19 overwhelming COVID capacity. So I think we need to be prepared. And I think it's really important for people to get vaccinated this year for those reasons.
Perfect. Thank you. There is an interesting question that I have. They're asking if there is any absolute contraindication for wearing any type of masks. We do see patients, I think almost every day, coming in and asking for a note to say that they're not able to wear it, be it their anxiety or their COPD or asthma. What would you advise?
So, the American Thoracic Society, the Canadian, the respiratory societies, we've looked at it. There is absolutely no contraindication to wearing a mask. Some people will say, I have allergies. They can look at different materials for masks. The only population where I find may be difficult is those potentially with some sort of disability or developmental delay, which may be challenging. But otherwise, there really is no significant contraindication at all for mask. And there really should be no reason why people should not be able to wear a mask.
Perfect.
And I also don't think that people, I think that, I've been asked a lot for these notes, and once you explain it to people and you explain the concept and the risks, they're actually really willing to go through. And I think a lot of it really relates back to what Professor Caulfield was saying. There's a lot of misinformation and a lot of misunderstanding. So I think if you take the time to really explain it to people, they're really understanding and that they're willing to actually take that step to mask up.
Perfect, thank you. And there is just one last question that I see. They're of course thanking you for the great presentation, and they're just asking if we should go back to regular screening for the patients now. You know, like routine screening for all the other conditions apart from COVID.
You know, absolutely. I think that we need to make sure that this backlog doesn't continue. I think, you know, we have to take it in stride, given the fact that we are going into second wave and the fact that we are potentially going into flu season and we are still limited with in-person appointments. So, but I think, you know, things like cervical screening and breast screening, like we've been doing now for the last month, they're slower, but I think we need to get back into making sure those preventative care measures are still being implemented to really decrease the cumulative impact that this may have on the healthcare system down the road.
Thank you so much. Thank you so much for answering the questions and a great presentation. It was a pleasure having you on here.
Thank you so much. I look forward to hearing the other speakers as well. Thank you.
Thanks. Before we move on to our next speaker, we all from APPNA Alberta chapter would like to thank all the sponsors for their generosity. And you should be able to see a slide with all our sponsors. Okay, so we would now move on to our next speaker, Dr. Raheel Syed. He is a forensic psychiatrist with Alberta Health Services. He has served as an expert witness in the general and forensic psychiatry to the Alberta courts. He was awarded the Canadian Academy of Psychiatry and Law Fellowship Award and R.H. Mewburn Memorial Prize in Forensic Psychiatry. I would like to thank him for joining us again on APPNA Alberta Forum and sharing his expertise. He will be talking about impacts of COVID-19 on mental health. Please welcome Dr. Syed.
Perfect. Thank you very much. So I'm just gonna, can you guys hear me okay?
Yeah.
Perfect. So thank you for the very kind introduction. So my name is Dr. Syed, and as she described, today I'll talk a little bit about the mental health impact of COVID-19 and what is expected to be the fourth wave in this pandemic that is ensuing. So I'll initially just go over a little bit about how COVID-19 is impacting different populations here in Canada. And then I'll put all the data in a little bit more in perspective. And then I'll give you some advice in terms of what we can do to maintain the stability of our mental health and the resiliency during such difficult and trying times. So first and foremost, it's very important to define this buzzword or this buzz term that everyone has been talking about. It's mental illness, mental health concerns, or mental disorder. And the way I boil it down in a way that makes sense is that if an individual is experiencing any emotional or behavioral problems that are starting to substantially or significantly affect your daily functioning, that's a little bit of a red flag that maybe you need to take some time to investigate this a little bit further and possibly reach out and get help, because it's always better to get help sooner rather than later, especially regarding issues related to kind of mental health. Now, there's other definitions, the medical and legal, and I've left them there for you guys to read at your own leisure there. Now, there's different types of mental disorders. The human mind is quite complex, and problems in different parts of the brain are going to create different symptoms and different problems. Commonly, at least when you look at the literature related to COVID-19 and the mental health implications, mood disorders such as depression, anxiety disorders, substance use problems, and sleep disorders are some of the more common mental health problems that seem to come up. And there's a whole host of different mental disorders that we're all aware of, but those are the ones that typically come up, and we'll kind of explore them a little bit more in detail. So I guess the next question is that looking at the Canadian population, what kind of mental health problems are we seeing? So if you look at a survey conducted by the Canadian Mental Health Association several months ago, what they found was that about 38% of Canadians feel as if their mental health is declining, and about 46% of them are starting to feel a little bit more anxious. In fact, the Mental Health Commission of Canada found similar results. They found about half of Canadians are noticing that their mental health is declining, and anywhere between 40 to 45% are starting to experience increased anxiety. Now, the anxiety piece is very important because, as our previous speaker identified, is that they can actually delay us in going into hospitals and getting care for physical conditions as well. For instance, if you're having a heart problem or a problem related to your appendix, people are quite worryful and scared that they might catch the pandemic if they even go to the hospital in a situation of that nature. So when we look at more specifically the mental health problems that are emerging, at least in the Canadian population here, we're seeing, as I mentioned, anxiety, depression, sleep disruptions. People are having difficulty sleeping, post-traumatic stress symptoms. So these are in individuals that have either experienced someone who suffered from COVID-19, they've experienced it themselves, or they're working in an environment where they're constantly seeing other people being affected with COVID-19. The social isolation practices are also creating a feeling of loneliness and isolation, and that kind of makes sense. And then there's just general psychological distress. People inherently are just feeling a little bit more tense than they normally do as a result of COVID-19. The other interesting feature is that the thoughts of suicides appears to also be increasing as well. So the Canadian Mental Health Association, they did a study where in 2019 or 2018, they found about 2.5% of the Canadian population experienced some thoughts of self-harm or suicidal thoughts. Whereas as of May, what they're finding that approximately 6% of the population has had thoughts of suicidal thoughts as a result of COVID-19. So this is quite scary because, as the pandemic looms on, we might start to see an increase in the number of completed suicides, which can be a very scary and disastrous outcome. When we look at the rest of the global community, the rest of the global community around the world is also suffering from very similar mental health symptoms. So commonly anxiety-related symptoms, depression, and PTSD. So essentially we have as Canadians a shared experience with the larger global community when it comes to mental health implications. Generally, we're all struggling with similar related issues in terms of anxiety, depression, and post-traumatic stress-related symptoms. So now, different people respond to mental illnesses in different ways. So no one person is the same, specifically individuals that have pre-existing mental health-related illnesses. And what the Canadian Mental Health Association found in one of their surveys is that if an individual has pre-existing mental health problems, such as depression or anxiety, they're more likely to find that their mental health is declining as a result of COVID-19. In fact, they're about 4 times more likely to have thoughts of suicide and 3 times more likely to struggle with coping. So if you're an individual or if you have a patient who has pre-existing mental health related concerns, it is important to kind of, keep a closer eye and closer tab on your mental health, because you will be one of the individuals that would be at slightly higher risk of having a deterioration. Now, children and parents. So COVID-19 has forced individuals, for better or for worse, to spend a lot more time with their families. And that has been a good thing, but in some respects, it's also been somewhat of a bad thing. What the survey basically showed is that about 23% of Canadians are having a lot more conflict with their children. And there's actually a lot more discord within the home as well. So verbal arguments and disagreements. Now, the important thing about this is that that's kind of expected, is that people are around each other more than they typically are. So inherently, we're going to notice, the bad and good sides of people. But it is important to look at what is actually happening to children, because children are still in the developing stages of their years, so their mind is still developing. And so what this report by Raising Canada found was that adolescents, particularly in the ages of 15 to 17, were reporting that their mental health was either somewhat worse or much worse. So that means that there is a growing issue of mental health problems amongst children as well. Of great concern is the issue related to child abuse. So the Kids Help Phones reported that there is an increase in the specific content of what these children are calling to talk about. And they're talking a lot more about physical, sexual, and emotional abuse that they're experiencing. The scary part about this is that given that COVID-19 is forcing individuals to isolate, kids are not as in contact with positive support, such as their teachers or friends, as they were previously. And so it might be much harder to detect a child who's experiencing child abuse because they're just not interacting with some of the positive supports as they were previously. Now, what about the flip side in terms of, before I get to that, one thing I found interesting was physical activity. So the physical activity in children has drastically reduced. In fact, less than 5% of Canadian children are meeting the physical activity guidelines that they should be, which is quite remarkable. I mean, it makes sense in that kids are spending a lot more time at home, so they're more likely to be on social media, computer, those kinds of things, as opposed to going outside because of the concerns related to COVID-19. But it is a substantial decline just in comparison to 2018. So this is important in that when we're thinking about the health of children, is that even though they're isolating, it's important to maintain healthy degrees of physical activity as well. Now, on the other side, parents are found, so parents that have children that are less than 18, they're more likely to not only experience symptoms of depression, but also symptoms of anxiety as well. And the anxiety piece is quite concerning because they're obviously worried about their future of their family, future of their finances, their household, those kinds of things. And as a result of that, what we're finding is that parents who have children less than 18, they're at more higher risk of having thoughts of suicide and also using substances as a form of coping as well. Substances and addictions. So in times of stress, substance and addictions always come to the surface. So a survey conducted by the Canadian Centre of Substance Use and Addictions showed that about a quarter of Canadians between the ages of 18 to 54 are consuming alcohol more than they were prior to the pandemic. Furthermore, these individuals that rated their mental health as lower or worse are more likely to use cannabis, tobacco, and alcohol. So if you already rate your mental health as being poor, you're more likely to use substances. It seems that overdoses are increasing, and I can speak to that in terms of in the Edmonton region, we definitely saw there was a small upsurge in the number of overdose-related deaths related to opioids specifically as well. The key message to take home from here is that if individuals are starting to use more substances or the excessive use of substances, this can potentially negatively impact the immune system, which is obviously important as we go into the winter months here, where there's going to be more infections and viruses floating around. So using substances more may inherently compromise your immune system and make a worse situation already even more worse. When we looked, when that NANOS poll looked at why people are drinking more, they found 4 common reasons. One was having a lack of a regular schedule. Second was boredom. Third was stress. And fourth was loneliness. So not having a regular schedule and feeling bored and lonely, people seem to be turning more towards substances as well. And when we think about maintaining or developing resiliency in terms of our mental health, these are some factors that we need to look at and address in such that our mental health remains strong throughout this pandemic. Essential workers. So what the literature shows in terms of individuals who are working with, directly working with patients suffering from COVID-19, or if you have a family member or a friend who has become infected with COVID-19, or if you've become quarantined, you're about 2 to 3 times more likely to develop symptoms of post-traumatic stress. And this is actually consistent with data from previous pandemics as well. The other concerning part is that if you were to develop such symptoms, studies have shown that they can persist for 1 to 3 years beyond the termination of the pandemic. So as the pandemic wears down, these symptoms can persist. The good news is that post-traumatic symptoms are treatable, and vast majority of patients do not go on to develop full-blown post-traumatic stress disorder. But it is important to just kind of keep at the back end of our minds that these mental health implications are there, and they can be quite severe and serious for individuals caring for those in the healthcare industry. There was a Chinese study that showed that about 40% of physicians and nurses were experiencing depression and anxiety and insomnia and distress. So as physicians, it's important to always have a checks and balances for you as well, and making sure that you're in tune with your own mental health and your physical health, and understand what your limitations are as well, such that if your health is deteriorating, it becomes much more difficult to take care of others. In terms of domestic violence, so this is a little bit interesting. Statistics Canada found 3 basically groups. So the majority of victim services agencies noticed an increase in the number of domestic violence victims that were coming to them, which was somewhat expected. About a third, so about 29%, felt that the overall number of their domestic violence victims that were coming to them actually remained roughly the same. And about 17% reported a decline in the number of domestic violence victims they serve. And that last piece is very concerning, because in situations where domestic violence is occurring, the perpetrator will use isolation and cutting people away from their friends and family as a tool to exercise control. Now, the environment in itself right now creates basically isolation. And so the reason the numbers might be declining, where 17% reported a decline, might be because victims are too scared to actually go out and get help, or because their partner's at home more than they were previously. So it's much more difficult for them to reach out and get that help. So the true gravity of what is actually happening on the domestic violence front will likely be felt as services to victims start to open up and pandemic restrictions are lifted. On the other side, police agencies are starting to get an increase in the calls related to mental health related concerns. And I can comment on that because I consult with the police assessment crisis teams in the Edmonton region. And it is true, like at least subjectively, I am noticing that we're getting more calls related to deterioration in people's mental health, whether it be related to severe depression or psychosis or substances, than we were previously. So one of the important things to discuss here is that we've discussed in previous talks the population and individuals that are at highest risk of developing COVID-19. But it's also important then to look at what groups of people are more likely to develop mental health concerns. And what some of the studies have found is that there's several risk factors. One is being female, and that makes sense because a lot of mental health conditions are somewhat more common in females than there are for men. For example, depression and anxiety, whereas substance uses such as alcohol are more common in men. Younger individuals, so less than the age of 40, unemployment, being a student, frequently exposing yourself to COVID-19 news, and having pre-existing mental illnesses, having kids at home. These are some key risk factors that are starting to surface in terms of those individuals that are at higher risk of developing mental health complications. Now, the news is not all bad. I don't want to make it seem like there's this doom and gloom and everyone is doing horribly. We have to keep in mind that the majority of Canadians are actually coping adequately. So what one of the surveys showed is that as a result of the pandemic, 66% are spending more quality time with their children. Majority of people are feeling closer to their family members. There's a lot more affection. People are connecting more virtually with friends and family. A good proportion of the population are still trying to maintain a healthy lifestyle. So despite the rates of mental health complications being there and increasing, the vast majority of the population at this point is doing relatively okay. Even when you look at substances, there has been an increase in the number of substances, but to put this into context, about 70% of Canadians report their drinking level has remained the same, and about 90% report that their cannabis consumption has remained the same. And in fact, some individuals have actually reduced the amount of drinking and their cannabis use as well. The last thing I want to leave everybody with is some advice in terms of how to maintain a degree of resiliency as this pandemic goes on, because it looks like it's going to go on for a little bit longer. Number one is that schedule how often you're accessing COVID-19 news. Studies are showing that people that are accessing it all the time are inherently going to be more anxious because there is that fear that is connected with it. So set a scheduled time. Monday, Fridays, and Sundays, you will look at news related to COVID-19 and updates. And I would say always look at reliable, consistent information, whether it be a specific news outlet that you trust, such as CBC or the CDC. So stick to kind of reliable news outlets, and that will help reduce the risk of misinformation, and you won't get as distracted by the misinformation that is out there. The next thing is establish a routine. If you have nothing to do in your day, you're going to feel rudderless. And an unoccupied mind is an evil mind. If you're not doing anything, you're naturally going to start thinking about things that you're quite worried about. The other is increase your physical activity. We have social distancing. Doesn't mean we should just sit down and bunker down in our homes and do nothing. You can go out, go for a walk, go for a run. If you're not feeling comfortable going to the gym, if you take up a new sport, try skiing. These are solitary activities that we can do in the context of COVID. Schedule some regular contact with your friends and family through social media platforms. So one of the protective factors is having strong social connections with people during this time of the pandemic because it allows a shared experience. Establish goals for yourself. And most importantly, you're in charge of your own health. So monitor your own mental health. There are different rating tools and scales that you can get, and once a month, sit down and score your depression on a PHQ-9 to see, are you getting better? Are you remaining the same or worse? And the most important thing is if you notice that your health is deteriorating or your family members notice that your health is deteriorating, seek out care. The last message I want to leave with everybody is establishing balance in your life. Our lives have different facets to them: career, your hobbies, your friends, community engagement, spiritual health, financial stability. If you focus on just one area and that area starts to go down, it may destroy you, which is why it's important to break up your life and have a balance between your career, your hobbies, and your friends. And if you feel that you don't have this balance, sit down with a pie chart and see where you're spending most of your time. Kind of move things around and say, hey, I need to start spending more time with my friends, or I don't have any hobbies. Maybe I should start developing some. Finally, here's some resources that I've left for individuals here in the province of Alberta. If you're in the Edmonton region and you require mental health supports, please contact the Access 24/7 clinic. It's open 24 hours a day, 7 days a week. You can walk in at any time if you don't know where to go in terms of mental health supports. You can also call us as well at any time if you require any assistance or guidance, or being connected to a therapist, doctor, or a psychiatrist. We can do that at this clinic here. So I want to leave everyone with stay safe, and it's tough times, but we're all in this together. And thank you very much.
Thank you, Dr. Syed, for really an extremely timely presentation that in so many ways, I think, fits so well into the format of this afternoon, in which we are perhaps endeavoring to utilize social media to bridge the gap of interpersonal communication, not merely to inform and educate, but to establish that sense of community that you've highlighted is so vital for our mental health. We have had a lot of interest generated from your timely presentation. And I'm wondering if I might ask you to address a question from an avid viewer who also evidently is a frontline physician, who's asked if you could perhaps specifically speak to those strategies that physicians can take to establish the important boundaries in order to preserve their own mental health, particularly when they're faced with the special challenges of being healthcare providers through the pandemic.
Excellent question. So one of the strategies that I recommend is having a small team. So having a small group of people, let's say at work, who understand where you are in terms of your mental health, and also sharing when you're burning out, because people, physicians and people are burning out because it is stressful. So having a small cohort of trusted individuals that you can openly share this information with when you are, and knowing that they can support you, is vital. The second thing is that scheduling time for yourself. And this is something where, as physicians, we're not that great at doing. And we blur these boundaries between when we're working and when we're supposed to have time for ourselves. Specifically these days where, you know, the demands are quite high in terms of our patients are calling us, other physicians want assistance. So establishing a specific time, so let's say 3 times a week from this hour to this hour, you're just going to focus on your own mental health. And that can involve things such as going out for a run. It's built it into your schedule, or doing meditation, or reading a book, or listening to music. Some constructive activities like that you should build into your schedule. And the key is that if we're not building those into our schedule, then the mental health itself will kind of go on the wayside. And it's easy to put that element on the wayside, and you don't realize the degree of impact it has had until it's too late, until you start noticing you don't care so much about your patients because you're feeling quite low and down yourself. You're feeling quite more anxious at work than you previously were. You're getting more irritable and frustrated. The last thing I would recommend is use a scale like either PHQ-9 or the GAD-7 to track your own depression and your anxiety. If you're doing well, great. But if you're not, physicians, we're very objective. We like to look at data. So then collect data on yourself to see how you're doing. Because sometimes if we don't actually pay attention to it specifically ourselves, we may not even realize our mental health is deteriorating.
Thank you so very much, again, Dr. Syed, for a presentation that at once highlighted the gravity, but also ended with some very practical suggestions and an optimistic note of encouragement. I'd like to take this opportunity to introduce our next panelist and speaker, Dr. Lynora Saxinger. Dr. Saxinger has achieved national recognition in the world of academic medicine and clinical quality of care and health resource stewardship. She's currently Associate Professor of Medicine at the University of Alberta and Medical Lead of Antimicrobial Stewardship for Northern Alberta with Alberta Health Services. Additionally, she is co-chair of Alberta Health Services COVID-19 Scientific Advisory Group. In addition to these impressive commitments, she has emerged as one of the prominent faces and voices of public education at both a local and national level. We'd like to thank Dr. Saxinger for joining us this afternoon and offering us a glimpse into what lies both behind the scenes as well as on the horizon. Dr. Saxinger.
Thank you very much for that kind introduction. Is my audio okay? I didn't have an opportunity to chance it. Okay, good. So I decided to basically start by going through a little bit of data, but not too much. And I can actually try to keep this pretty snappy so we have time for questions. Are my slides showing okay? So briefly, where are we now and where will this go? Now, I don't have a crystal ball, but I can hypothesize with the best of them. I'm going to start with just giving a brief current picture worldwide, touch briefly on really big picture what we've learned, talk a little bit about some areas of confusion and controversies, which will actually tie in a bit with what Dr. Caulfield had been talking about before, and sketch out what I think the way forward will be. One of the things that's going to come up is you'll find that I use a lot of modifiers like we think, It is possible that, and I would actually say that that's a good sign. And if you have anyone telling you with great certainty what's going to happen in a new disease, in a new pandemic, you should probably just very slightly distrust them. So this has been very devastating. Case and death numbers may be undercounted in many places, but even with that, there have been over 42 million cases and over 1.1 million deaths. The map doesn't display very well on my screen, but it basically gives you an idea of some areas that have been much, much more hard hit. And this has been waxing and waning across the globe. Now, one of the reasons I wanted to highlight for that disparity is that the number of that density of population makes a big difference. And if you look at places where there might not have been excellent case counting, but nonetheless, you can look at just the sheer numbers of people dying during the COVID epidemic in that region. There were 2,500 to 20,000 extra deaths in London, Madrid, Stockholm, Jakarta, Istanbul, Moscow, Santiago outbreak. So many different places in the world characterized by a dense population and lots of spread. In Stockholm, I highlight this one because they had over 2,000 extra deaths, and that's a city of less than 1 million. There's not that many people in Sweden. And so that to me is a bit of a cautionary tale of what a severe outbreak can look like in a city of moderate size. There've been some really, really huge outbreaks, and those graphs basically show the surprisingly consistent baseline number of deaths year over year in the green line, and then the red line is what happened during their COVID pandemic. So a 270% increase in Peru, for example. Now looking at what happened in China, that hit the news. People felt that that sounded very severe, much worse than SARS 2003. But China rapidly contained their epidemic and has actually continued to suppress it very successfully. The spread was mostly to large travel hub cities initially, but then as time has gone on, that has traveled to smaller kind of decentralized cities in a lot of places, including in the US. A lot of countries had significant undetected spread and later ineffective epidemic control measures. So there was a big problem before it was even recognized fully. And geography plays a big role. So one of the reasons I think we're kind of challenged in Canada is that we are sitting right on top of the US, which has easily tenfold our case rate. And we have a really long border with the US. And so it's not quite the same scenario as someplace with New Zealand where they can basically pull up the drawbridge. Just looking at the number of cases per 1 million people across the world, the USA number of active cases per 1 million people is really very, very high overall, with a lot of variability between regions. Canada is relatively modest. I'm just going to point out that in Alberta, our case numbers, Montana is also on here, I believe, are about a tenth that of Montana's, like just right on the other side of the border. And Alberta, nonetheless, is still twice as high as BC in terms of number of active cases per 1 million. And the other thing to look at is the shape. And so on this slide, I'm just showing examples of some countries. So at the bottom here, Taiwan is basically flat compared to India. Pakistan seems to be doing quite well. Norway has been doing well compared to Sweden, which is way up here. Canada is in this middle zone, I would have to say. And our shame, I think, is the long-term care-based deaths have been the majority of our deaths. And then you see these really shocking, sharp upswings in places like Mexico, where there's also significant undercounting of cases. So this is actually a low estimate. And the bulk of infections right now are about half in North and Latin America. And it's increasing again in the European Union, in the UK, and also in India. There's been kind of a long, slow increase. So we have not learned nothing about this. We've learned a lot about this, especially looking at, although it seems a really long time, a pretty short timeline. SARS-CoV-2, the virus that causes COVID-19, is about tenfold more lethal than influenza. And of course, we know that every year we have lots of people in hospital and in ICU with influenza. That varies a lot across age. So there's barely any signal at all in younger people. In middle age, it starts to go up. From age 50, 60 and up, the lethality increases markedly, like severely. This can be a nuisance illness, but for some it is clearly deadly. And it's actually interesting, the biology kind of feeds into this. So it's a very stealthy virus. It spreads much more widely and quickly than SARS or influenza did, because there really is a high level of virus in the upper aerodigestive tract very early in infection. And so this leads to spread while people can have fairly minimal symptoms. They're still feeling well, they're out and about. They might be in the phase of wondering if they're getting sick, and they could already be spreading infection to others. And this makes it incredibly hard to control. Another factor is that there's a wide dispersion of the spread. So a small number of people are responsible for a lot of the spread. Some of the modeling studies based on transmission have suggested that about 10% of people account for about 80% of new cases. This also makes it hard to control, because even if a lot of people do the right things, a few cases can spread very widely. So another factor, there's no significant existing immunity in the population. There might be some tiny bit of cross-reactive coronavirus immunity that might modulate disease in kids, but this is containable if you deny it fuel. So I keep on getting the image of a fire shooting off sparks. And if it lands on tinder, it will keep on flaming. And if it lands just on bare ground, there's, everything's spread out very widely. You're not going to have that contagion continuing to spread. This is why lockdown worked. Lockdown is a very blunt instrument, but that's why it's also highly effective. And so it's kind of the last ditch effort. The cornerstone of control, if you can't actually eliminate, is to test and trace and isolate. Find cases early, quarantine them, find their contacts, get them to be quarantined before they can spread infection. So you're trying to basically create a ring around cases where there's not going to be outward spread anymore. That's challenging because it really depends on timing. I'm just going to point out something. I think there's been some blurring of the messaging, and people are getting the idea that this is not a highly fatal condition for overall, especially in countries that have had case undercounting. The case fatality rate has exceeded 10 to 15% of documented cases. So that's missing a lot. In places where there's been pretty good counting, I would count Canada as one of those. The case fatality ratio is usually in the kind of 2 to 4% range. In Canada's case, actually, it's moderately high because of the long-term care issue. I don't think that we shielded our vulnerable optimally there, and I think that's really a shameful thing. Now, other things we've learned that I think are really important and should form a cornerstone of how we talk about this is factors that influence transmission, because this is the place where you yourself can actually start to impact how things spread. So in terms of the source individual, if you have symptoms like cough and fever, you're more likely to spread the infection. Pre-symptomatic though, so just as you're getting symptoms, you can still be quite highly infectious, although it's about 37% less risk. This is all based on epi studies, which are imperfect, so I reserve the right to change this slide. Asymptomatic exposure is 65% less risk, but because asymptomatic people are not usually isolating, they actually can be responsible for a lot of transmission in the community. Mask as source control. Now this is based on pretty thin data, but likely decreases the risk of spread by about 80% just because you're containing droplets before they go. And then infectivity is really highest probably 1 to 2 days before developing symptoms through 4 days after symptoms. And it really drops markedly after day 6. And so if someone is past 6 days of symptoms, it's relatively unlikely that they would spread unless they're immunocompromised. This is actually maybe one of the reasons we have not seen such devastating hospital outbreaks as we did in SARS 2003, because in that case, the virus peaked in the lungs much later when people were in hospital, and there was a lot more transmission within hospitals for that reason. Now in hospitals, I think bigger risk is from people that you don't know have the disease, so early in infection, and coworkers who are early in disease. The personal protective features are mask, eye protection in healthcare settings, gowns and gloves, donning and doffing. And actually, there is some issues around susceptibility. People who are older or have comorbidities are more likely to manifest severe infection. Additional risks would be if you're in a demonstrated high-risk scenario, for example, your contact has already been known to transmit to others. And setting risks, indoor risk is about 20-fold, 18.7-fold. Seems unnecessarily accurate given the degree of data we have, but about 20-fold higher risk indoors than outdoors. Poor ventilation, potentially inadequate cleaning of high-touch surfaces. And there's been some controversies and confusion. One of the hot button issues that I see evolving is this concept of herd immunity and whether or not we should just be letting this spread in the healthy. I don't think that that is reasonable for a number of important reasons. And that vaccine-induced herd immunity is a much better goal. The other issue I think that's gotten quite polarized in the public eye is the idea of lockdowns, where it seems like people are conceiving that either we're completely locked down and no one can do anything, like back in April, May, or we should just do whatever we want. And in fact, there's a lot of things in between there that could be very important. And I think that's the space that we have to negotiate for the rest of the pandemic. So herd immunity briefly usually refers to vaccine coverage, not natural infection. It's unclear how long natural immunity may last. It does appear to be somewhat protective for some months. There's starting to be cases of reinfection. We don't know how common that will be. Some coronaviruses, the endemic ones, the immunity lasts less than a year. For SARS and MERS coronaviruses, the epidemic coronaviruses, some people seem to have long-lasting immunity. And a big theory being put forth is that T-cell immunity may have a role that we're not able to count with the current testing. And therefore, maybe there's more immunity than we think in the population. The current shapes of the second wave, and also the fact that T-cell immunity might be more likely to reduce severity of infection than to actually reduce being infected, I think make that a limited concept because people could have less severe infection but still spread it. So I don't know if that we should pin any hopes on that at all based on current data. And it's estimated that between 50 and 75% of the population would need to be infected. Another issue is that once we pass the magic number, the epidemic will continue for a period of time as long as there's susceptible people in contact. The idea of herd immunity refers to suppression of the next epidemic. So there would be some excess deaths. And the infection fatality ratio is really settling out between 0.5 and 1% of all infected people would die. And therefore, that would be the cost of that uncertain chance of herd immunity. And shielding the vulnerable is a very compelling idea, but it's actually not been shown to work anywhere in spite of efforts in other countries, particularly in Europe. The other issue is, of course, lockdown. No one liked to lock down. There are harms from lockdown. We've heard a lot about mental health harms, delays in needed care, financial strain, unemployment, suboptimal education, a disparity effect of affecting the poor more. And many harms, however, could be from the pandemic itself, not just lockdown alone, because countries that did not have the same degree of public health measures also have seen massive drops in their GDP. So we can't forget that it's not just the lockdown, it's also the actual pandemic and the human cost of that. So I think that there's been a bit of a battle in the public eye, which seems to suggest that public health wants to lock down. I don't think public health wants to lock down. I think public health would like to avoid that because that is another kind of harm. And I think it is important to really look at lighter touch targeted restrictions and figuring out, starting aggressively, getting things suppressed, and then figuring out where we can manage, because this is not going to go away very quickly. This needs a lot of public trust and buy-in to make it work. And then finally, coming to an end, I'm actually very optimistic that some of the vaccines in development, I used to keep a rolling total, but now it's actually much beyond what I had before, probably over 170 vaccine candidates in trials. I think that we're going to have more than one decently protective vaccine. Rolling out a worldwide vaccine is fairly insensibly is a really big task. And so I'm not going to delude anyone to saying that this is easy. But all of them basically use a piece of the virus to train your immune system when I'm describing it to patients. The ones that deliver with another virus vector, like the adenovirus ones are the ones that are farthest ahead. They're also very unique, and we don't have a lot of experience with these in the field. There's other RNA-based vaccines that deliver a piece of RNA, and then we make our own viral protein and immunize ourselves with that. Also quite unique, less experience in the field, but there's no need to handle a replicating virus. And there's also just more conventional subunit vaccines where there's a manufactured piece of the virus as part of the vaccine. Those are a little farther behind in trials. Will they be safe, effective, and accepted? It's crucial that these get fully tested. There's certainly urgency, but you can't roll out an unsafe vaccine. That will be incredibly damaging. Vaccines have the highest safety standards of all medical interventions. We have to uphold that. And even partial effectiveness can make a huge difference based on even our experience with influenza, where the vaccine is actually not that excellent, but it reduces mortality. And acceptance is a big question, and how we message this is going to be incredibly important. But at the end of the day, most people are actually very reasonable, and I think that this is going to be manageable. So the next steps, empower. I think that we have to keep adapting our evolving knowledge to be clear, to give the best possible advice to people about what they can do to reduce risk. I also think we have to be very steady in that we don't want to mislead individuals or don't get misled by individuals who are sure they're right. And to diagnose and treat where the transmission is happening. So our restrictions should target where the problem is. Ensure that people can take quarantine and sick days, that's financially possible for them. I think lockdowns remain in the back pocket as a backup plan to suppress the epidemic should it get truly out of hand. And that decision has to be earlier rather than later, given the nature of epidemic spread. And vaccines will be the goal and also the next challenge. But I'm actually thinking that if we can just maneuver our way through the fall and winter, that 2021 stands to be a much better year than 2020. It'll be a work in progress though. So I'm happy to stop there. It was pretty fast though.
Thank you so much, Dr. Lynora Saxinger. We do have some questions for you from our viewers. So for homeless, there's a question from one of our attendees. They've said, for homeless population and asymptomatic spread, how can we effectively protect this population with flu season approaching?
This is a really difficult population. There's been some efforts actually trying to make sure that people have access to, I guess, safe, well, not really housing, but safe shelter, and maintaining good standards of hygiene and distancing and hand washing and testing in those shelters. And I think that's going to be crucial for that population. And also, of course, flu season has been effectively suppressed, for example, in Australia. So the measures that they took to reduce the risk of COVID did in fact reduce the risk of influenza quite a lot. And so I'm hopeful that those things will work here as long as we're actually going with that and applying those basic measures very, very well.
Thank you. And also there is another question asking if what are the chances to have the vaccination available to public during this winter?
That one is interesting. I mean, I know that there was a suggestion that we might even have vaccine available this fall. I actually don't think that's highly likely to be available to be administered. We might see completion of phase 3 trials this fall. I think the rollout would be to the most high-risk populations, and it seems unlikely to be before the early part of 2021.
Thank you. Another question that I have, and it's basically asking if the flu vaccination will give any sort of protection from COVID-19.
Yeah, the viruses are too different for there to be direct protection. I think the main reason that there's a big push on for flu vaccine this year is because we already know that our hospitals get overfull every single Christmas, New Year's kind of period. When I'm on call, the ICU is full to the rafters with flu cases, and we just can't have that when we're also dealing with a COVID pandemic. And also early actually in COVID, there were some co-infections where people had both viruses, and that's not necessarily a good thing either. So it's more general principles than an idea of cross protection.
Thank you so much. And I do have another question from one of our colleagues. What would you say about the less number of cases in the developing countries as compared to the developed countries?
That's very interesting, isn't it? And I think there's two things to watch out for. One is looking at the excess death data because there's been limited testing in some countries. The other thing is I think that the public health infrastructure in some of those countries actually mobilized very well. And so actually acted quicker than some larger countries that, you know, have theoretically many more resources. And so much of it depended on getting those pretty low tech basics right initially, that might be a reason why some of those countries have done actually very well. The other question is whether or not they're really doing that well, but that will become clear, I guess.
Thank you so much. Thank you so much, Dr. Lynora Saxinger. Our viewers are extending their thank yous as well for such an informative talk, and it was a pleasure having you on here.
It was my honor. Thank you.
We will now move on to our last speaker. It's a bit of a different topic other than COVID-19. Our last speaker today is Dr. Zubia Mumtaz. Dr. Zubia Mumtaz is a professor of global health and program director in the School of Public Health, University of Alberta. A public health physician, her research is centered on global maternal and reproductive health. Her research focuses on developing innovative solutions to provide equitable, high quality healthcare services to women living in remote rural areas. Her global mental health research program is the first of its kind at the University of Alberta and focuses entirely on Pakistan. She has published extensively and has won numerous academic awards. In 2019, she was inducted in the Royal Society of Canada in recognition of her intellectual leadership in the field. Please welcome Dr. Zubia Mumtaz.
Assalamu alaikum, everybody, and thank you very much for the kind introduction. So I will start my presentation here. So, it's my great pleasure to have this opportunity to share my research on the APPNA platform. Here we have been listening to a number of speakers talk about COVID and how it is affecting our lives. My presentation is going to be significantly different, and I'm just going to change gears here and talk about how can we deliver services to maternity health services to poor pregnant women in some of the remotest parts of the world with fragile healthcare systems. This is Rabia. Rabia, 19 years old, Zahida, 22 years old, Samina, 23 years old, and this is little Asad, he's 2 years old. His mother's in the insert above. You must be wondering, why am I showing you these pictures of some young brides? The thing that links all these young girls is that they all are dead. And they died in childbirth in my one small field site in a village in Chakwal when there was no pandemic. And this is a small village, about barely 1,280 people. And Asad here is really an orphan. There is no mother figure in his life. Unfortunately, this is a very common thing. This is a very common thing. And over 300 women die in childbirth every year. This translates into nearly 800 deaths every day, which is about 4 aeroplanes crashing every single day. So can you imagine the hue and cry if 4 planes crashed every day? But this does not happen because the vast majority of these women are poor women living in some of the remotest areas of the world and some of the poorest countries of the world. And this slide here shows where most of these women live. As you can see, they're largely in sub-Saharan Africa and in South Asia. And these women died because they did not receive the care that they needed during childbirth. The majority of the women that died in my fieldwork, they had only received care from a traditional birth attendant. We at the University of Alberta now work with the government of Pakistan to try to ensure that every woman giving birth in rural areas, but especially the poorest women living in some of the remotest rural areas in Punjab, receive safe, high quality maternity care. So in the remainder of this presentation, I will share with you what we have been doing in partnership with the government of Pakistan to deliver these services, and the risk of the COVID pandemic undoing nearly 2 decades of our work. The first thing we started off was by trying to replace the traditional birth attendant with skilled midwives. To do that, the government of Pakistan established the community midwife program. So this program essentially selected village girls, at least one girl from every village, who had about 10 years of an education, and provided them with 18 months of midwifery training. These girls were then deployed back to their home villages, and they were provided the equipment so they could establish home villages and provide domiciliary care to women living in these villages. So the idea was to provide them with the home-based services that could provide them at least safe childbirth services at home. The government trained nearly 8,000 of 8,000 midwives. Uh, when I, when we went in, my research went into check if these girls were providing services to the poor women for whom they were essentially trained to do so. But instead, what this is a picture of clinical practice, a home-based practice of these midwives. And what we found were that 77% of them were not working. 16% of them were struggling to establish their practices. And in fact, only 6% of them managed to establish their practices. So we went in to explore what was going on and why had these girls struggled so hard? Why were they struggling so hard to establish their practices? So our research found that there were many complex and interlinked factors of why the midwives were not working. They continue to experience significant competition from the traditional birth attendants. They experienced mobility restrictions. Pakistan remains a context in which men are expected to provide. And so gendered norms of male provision prevented these girls from working. Midwifery remains a low status stigmatized occupation, and people who could afford not to have their daughters work did not see the point of them working in such an occupation. At the end of the day, these girls lacked clinical and especially business skills that were required for them to establish their private practices. So, for example, our midwives were located as providers in the private sector, expected to a fee to be paid for the services they provided. And although the government had required them to charge low fees, they were still charging something in the range of 3,000 to 4,000 rupees, which sounds a minute amount of money for us, but for these very poor women, they could not afford even those kinds of fees. And they continued using the traditional birth attendants who can, traditional birth attendants can be paid with a sack of flour or a chicken or something. So clearly we had not been very successful in our strategy. And the other thing that kept on, that prevented these women from working were gendered mobility restrictions. So Pakistan remains a context in which girls, especially young girls, cannot travel alone. And they could definitely not travel alone to provide services to a scattered population living in significant distances without any means of transport. And evidence shows that babies are more likely to be born at night. So it was impossible for these young girls to travel at night to places like this and this to provide services without the company of men and a father, a husband, or a brother. And in some cases, as you can see from this one, they needed to have at least 2 men accompany them. It can be pretty risky traveling at night to provide services in these remote areas, in these scattered settlements. In fact, one of our midwives did go and provide service in this site, and we thought that she put herself at significant personal risk. So clearly, and the other thing that happens is that if something does go wrong, the midwives were clearly not equipped to handle emergencies. And it really are these emergencies which kills the mothers. So clearly we had to go back, and we went back to the drawing board to see what could we do to provide the services, and what was the best way to promote, to provide the safe childbirth services. The government of Pakistan decided, with technical assistance from a lot of universities, that really it was the health facility delivery was the best way to approach. But hospitals are few and only available in cities and towns. And as we all know, it is next to impossible to build a hospital for every village. However, there can exist in Pakistan a vast infrastructure of facilities known as the basic health units. These basic health units are primary care facilities originally designed, established in the 1980s to provide just primary health care. But the government decided that maybe these facilities can be transformed to provide maternity services. And there is a vast range of them. There are nearly 3,000 basic health units in Punjab alone. There's one basic health unit for one union council, which provides coverage to about from 30,000 to 50,000 people. So, but these basic health units were in pretty bad shape. This was the condition of the labor room. And this was the condition of the backyard. And this was the condition of the staff residences. So this was a huge initiative to make these facilities functional. To do so, the government launched the 24/7 BHU initiative. This initiative was launched with funding from the British government and the World Bank, and the University of Alberta, along with a number of British universities, provided the technical assistance. So this 24/7 initiative essentially first started off by renovating the infrastructure. As you can see, the significant renovations were done. And more importantly, large structural changes were made in how funding was sent to the basic health unit level to do the renovations. Equipment was provided. As you can see, there's baby warmers, oxygen tanks, significant amount of equipment was provided. Drugs were provided. The drug logistics supply system was smoothed out, and high quality vendors were recruited to provide the medicines. An army of new midwives were recruited to provide round-the-clock services. Remember, these basic health units are located in very remote areas. And to make sure that the girls could work and be present there both in the evening as well as at night, the staff residences were renovated. And these were, we managed to recruit the girls who had been trained to be community midwives, but had been unable to establish their private practices. An ambulance system was established using a public-private partnership. And most interestingly, we have developed a monitoring and evaluating supervisory system in which retired army jawans have been recruited, and they make random visits to collect very fine granular data about the services that have been provided. They make sure are drugs available, was the oxygen tank filled, is staff available, everything is collected. I think all this work has had some kind of impact, because as you can see from this, this chart here, the maternal mortality ratio, which is for the lay people here, a technical term that we use to measure the maternal deaths, has been gradually decreasing in Pakistan since 1990 and much more accelerated after 2000. But as you can see that we still have a long ways to go. The line at the bottom is the Canadian maternal mortality ratio, which is nearly close to zero compared to what Pakistan is. But nonetheless, the trajectory is downwards, and we are hoping that we are making some progress. My current research is now going in to explore if this 24/7 BHU initiative is actually being implemented as planned. And in particular, we are now focusing on quality of care. whether the quality of care that is, we have provided the drugs and the infrastructure and everything else, but is the quality of care meeting evidence-based practices? Our fieldwork was interrupted by the COVID lockdown, and we have now restarted the fieldwork. But it has become apparent that the COVID pandemic is really impacting the delivery of maternity services. It is undoing a lot of the work that has been done over the past 2 decades. For example, this is a context where staff absenteeism is very common, and staff are recruited, they're paid a salary, but they don't come to work. To make sure that the staff were attended, came to work, the government established a biometric system to basically capture as digitally staff attendance. This biometric system was stopped during the COVID pandemic because it meant that they had to touch the screen with their thumb. And that was then taken as an opportunity for the staff to not come to work. Absenteeism seems to have arisen again, and as is common in these parts of the world, they have even some of the biometric machines have been deliberately damaged. Nonetheless, modeling and this might have an impact, for modeling shows that maternal deaths will increase by anything ranging from 15 to 40% as a result of COVID. This will translate into nearly 60,000 additional maternal deaths, which are above and beyond what was happening before COVID hit. And 60% of these deaths will simply be due to reduced coverage of just 4 childbirth interventions, reduced parenteral administration of antibiotics, anticonvulsants, uterotonics, and a lack of a clean birth environment. However, this does not have to happen. All these are projections, and but what they show that if routine healthcare is disrupted, the increase in maternal deaths will be worse than what the pandemic itself will have the effect of the pandemic itself in this young population. So these modeling numbers are basically just tell us that we need to remain vigilant and to provide the necessary resources to make sure that the minimal coverage is make sure minimal coverage. Anyways, the pandemic is ongoing, and we really don't know what is happening in Pakistan. Only as Dr. Lynora said, that only time will tell whether the pandemic had a real impact or just that we failed to measure it. But nonetheless, we are hopeful that things will improve by the end of this year, and we won't have any of these additional maternal deaths. So thank you very much. That's all I have to say.
Thank you kindly, Dr. Mumtaz. That was really a very inspiring and engaging presentation that was a departure from what was the prevailing theme of the afternoon, but was important in drawing our attention to the acuity of basic health needs that persist even through the challenges of the pandemic. Thank you ever so much. I was wondering if I could just ask a couple of questions. One was, I was interested, of course, in the slide that you shared about contrasting Pakistan's maternal mortality as a barometer of maternal health with Canada's over the past 2 decades or so. And I think that perhaps might be a representative slide that talks about the disparity, as well as, the strategies and commitment that Canada has shown to maternal health as a very early public health target. Are there some We've talked about it within the realm of the pandemic about certain vulnerable populations, homeless, the economically disenfranchised, and indeed the indigenous population. Notwithstanding the overall trends in the developed world, are there some subpopulations that are still susceptible and that would benefit from cross-pollination of your experience with your project in Pakistan?
You know, in general, the Canadian healthcare system is resilient enough to be able to respond to all to the I guess the shock it has received because of the COVID pandemic. And for the most part, it's not a problem. One group of populations that can experience potentially reduced services are the indigenous populations, especially those living in northern areas and people who living in inner cities. A lot of work in a lot of care in Canada became virtual, and including maternity care, and that can have an impact on people who may experience challenging in accessing the virtual care. But that said, we really are not doing any research around this. There have been a couple of projects that have been launched in the UK to understand the impact of the pandemic on maternity services. But there's only been a little bit of information trickling in about increased rates of C-sections, so that patients instead of staying there for a few hours, in and out kind of services. But we don't have much information on what has been happening around maternity services in these countries.
I see. Thank you. I've also noted, like yourself, on my periodic visits to Pakistan and that part of the world, that there seems to be an interesting juxtaposition in how patients in unforeseen regions seem to embrace at some level certain technologies in a way that might seem startling and surprising. Point in question, perhaps, in how Muhammad Ibrahim next door in Bangladesh capitalized on cell phones as effectively empowering women in villages economically. And on the other hand, there seems to be a reluctance to embrace certain other types of technologies, such as your experience with the biometric technology that was attempted to be introduced as a quality care measure at the 24/7 BHU. Have you, as part of sort of the ongoing assessment of strategies, looked into which of these strategies and technologies your target population seems to be more avid about embracing? And I wonder why.
That's an interesting question. The thing that has really been embraced very strongly is the ultrasound in maternity services. And we're not really sure why, but it appears to us that with the possibility that the average person thinks that ultrasound is somehow therapeutic.
I see.
Yeah, and that is that. In fact, the ultrasound services has really increased women's access to services. They would never have sought out maternity antenatal care for all the benefits that we want them to seek out for, but they do go for the ultrasound. And it seems to me that you would think that ultrasound may be used to identify the gender of the child or something, but there's some evidence that's starting to seem that they think it is actually therapeutic in itself.
Okay. Well, I wonder if that can be capitalized on to highlight the downstream interventions that do impact outcomes. Really a fascinating observation, one that probably the radiologists amongst us might be a little bit bemused by. It's always interesting to contemplate the prospect of a therapeutic ultrasound.
Yes, I couldn't believe it. It was the language they were using.
Yeah.
And then it has been used very smartly by the providers. The providers know that if you want to increase your patient count amongst the private providers, the private sector providers, they always use ultrasounds. The ultrasounds have been used as a marketing tool to bring in more patients.
It's interesting, highlighting the realities of, shall we say, the art of medicine and how it intersects with our aspirations to implement an effective public health strategy. Well, may we reiterate our thanks, Dr. Mumtaz. It was a very welcome departure, though not merely tangentially related to the discussion about our overall health and well-being. Thank you again.
Thank you.
Well, as we're nearing the end of this afternoon, I did want to also convey an expression of thanks to those members of the Alberta chapter of APPNA who had been working behind the scenes and who I assure you are as, I would submit as equally photogenic as many of our panelists and our MCs. But have been content to be unsung heroes behind the scenes. So may I convey a hearty and heartfelt thank you to all the members of the Alberta chapter who have been working behind the scenes with a real spirit of dedication to get the word out about getting the word out, which is really what this afternoon's presentations have been all about, an aspect of education and building community. I'd also like to once again reiterate our thanks to our sponsors, who again are important unsung heroes, if you will, but shall not remain so. We'd like to thank the administration and staff of Saddletown Radiology, Stampede Pharmacy, New Aid Pharmacy, Martindale Pharmacy, and Branchland Pharmacy, as well as Judith Sheikh, all committed community patrons for the event. Thank you all. Now, as we begin to end the home stretch, the one very important thank you I want to affirm is our gratitude to all the attendees in the audience and the community who have really made this such a gratifying event. It really has been in your interest and with you in our thoughts that we have actually formulated and planned this event. And it really wouldn't have been without your participation that we could boast of really any degree of success in attempting to counter the misinformation and disseminate evidence-based information pertaining to the pandemic. Now that you've been recruited into the fold, I think we're going to ask each of you to do your part in spreading the good word, while of course taking care of yourselves and your loved ones. Nearing the end now, I will endeavor to segue into an introduction of one of our colleagues who will be making the closing remarks. And in setting the stage for him, I'd like to share perhaps an anecdote that the literary or even perhaps the sports enthusiasts amongst you might be familiar with. Some of you English enthusiasts will be familiar with the popular reference text of Bartlett's Familiar Quotations, which lists amongst its entries the shortest poem in the English language, which has been entitled simply On the Antiquity of Microbes, a timely topic perhaps during this pandemic. And the poem simply reads, Adam had 'em. Sports writer Norman Mailer reports, that on witnessing boxing legend Muhammad Ali's address at a commencement ceremony for one of the Ivy League colleges in the US, he witnessed as he was requested to grace the audience at that time with one of his famous and spontaneously delivered poems. At that time, struggling with Parkinson's disease in the twilight of his career, he responded in subdued tones and looked at the audience and said, "Me?" and then raised his fist defiantly to his disease and said, "We." Me, we. Norman Mailer is said to have written to Bartlett's and insisted that, now listen, that's shorter than Adam Hadam. But I think it is a perfect capsule, if you will, of the spirit of collaboration, cooperation, and community that our final speaker and Alberta chapter member, Dr. Bawa, has epitomized in his career. Dr. Hassan Bawa has a long-standing commitment to fostering interdisciplinary collaboration and public awareness. He currently works as a psychiatrist with AHS and as assistant clinical professor at the University of Calgary, involved in the teaching of medical students and family medicine residents. He's earned awards in 2003 and 2015, acknowledging his excellence in clinical teaching and his efforts at public education and patient advocacy in the realm of mental health. Thank you, Dr. Bawa, for joining us.
Thank you very much, Dr. Siddiqui, for kind introduction. On behalf of APPNA Alberta membership, I'm thankful to APPNA Alberta Executive Committee, Program Committee, and School of Public Health and Hygiene, University of Alberta, for choosing such an important and relevant topic for today. This is APPNA Alberta chapter 2nd APPNA Health Day conference. I must say that to run this program, a lot of people, as Dr. Siddiqui mentioned, that there are a lot of unsung heroes. They have worked really very hard to organize this program. I'm thankful to our speaker, especially to Dr. Saxinger, who is on call, and still she makes some arrangement to come and deliver her presentation. I must say that all presentations are evidence-based and they are really excellent. I'm also grateful to all the sponsors who have supported this program. And without their support, it may have been very difficult. Lastly, I would like to thank to all attendees of this webinar who have made effort to attend this webinar, especially on this sunny Sunday after 3 days of snow dumping, at least in Calgary. I don't know about Edmonton. I'm sure Edmonton was very similar. May I also remind you all that this program was recorded on Facebook, APPNA Alberta Facebook page, and you can refer back in future, or you can share it with your friend. There's a lot of good information, starting from myth of the misinformation to the how do you assess and how you treat and what will be very likely in future. Nobody knows, but at least from today's presentation, we got some idea and how we should handle it. Also, the anxiety about or what is going to happen in future we may have some learning from this presentation. So I'm thankful to all of you who have attended, and special thanks to all speakers. Congratulations to all organizers. Thank you very much, and over to Dr. Siddiqui.
And Dr. Imam.
Yeah, and Dr. Imam, yes.
Thank you for your closing remarks.
And we'd just like to reiterate our thanks to the audience. We did attempt to try to incorporate your timely and insightful questions into the presentations for our speakers. For those that we could not answer directly, we will attempt to try to compile resources that are perhaps relevant to some of the questions that have remained unanswered in the various links that have been suggested by the speakers and presenters, as well as additional links that will address some of the questions that we were not able to specifically address during the presentation. Thank you all from all of us for spending your Sunday afternoon with us. As I said, I think you've now been recruited into the fold, and if it did need to be mentioned at all, indeed, we are all in this together.
Thank you so much, everyone, and to all the organizers that have worked really hard. Thanks again, and have a great rest of your Sunday.